Good evening, everyone. Welcome to our session this evening. We're delighted to welcome an outstanding panel of experts to our latest episode of our Living Well with Cardiovascular Disease series. And this month, to mark World Heart Rhythm Awareness Week, we're focusing on atrial fibrillation. And we'd like to thank our partners, Johnson & Johnson, for their support in this webinar. I would like to invite our panel to join me by turning on their cameras. This evening's experts are Ed Cherry, our patient expert who was diagnosed with and treated for atrial fibrillation, Dr Niamh Hannon, consultant in Stroke and Geriatric Medicine here in Galway, and Dr John Keaney, consultant electrophysiologist in the Mater and Blackrock Clinic in Dublin. I'm also delighted to welcome a wonderful special guest moderator this evening, Trish Galvin, an advanced nurse practitioner in Stroke in Galway University Hospital. We've had lots of questions submitted in advance, and we will do our best to address those throughout the discussion this evening, but we also welcome you to submit more questions through the Q&A function at the bottom of your screen, as well as make any comments that you'd like to using the chat function. So I will pass over to you to take over for the session, Trish, and thank you very much to you all for being here.
Thank you, Lisa. And I'd like again to welcome everybody to this evening's Living Well series with Croí. Tonight we're talking about atrial fibrillation. Now, you may hear atrial fibrillation being referred to as AF or AFib throughout the talk. I tend to call it AFib because when you say atrial fibrillation quite a lot, it does tend to roll on the tongue a little bit. So AFib, what is it? It's an irregular heartbeat, an arrhythmia. But tonight I'm joined by Ed, John and Niamh, who will talk a little bit more about AF, about the diagnosing AFib, diagnosing and how you can be diagnosed with it. We will look at some symptoms you may or may not experience, and then the various treatment options that are available. So Ed is a lay person, sorry Ed, who is a patient, who is a person who has lived with AFib, and he is going to share his story with us. John is an electrophysiologist who looks after treating people with atrial fibrillation, and Niamh is a stroke physician. And you're wondering, what's a stroke physician doing talking about AFib? Well, Niamh will join up that link, and we will discuss that later on. So Ed, if you don't mind, we might start off with you. And if you don't mind talking us through your experience of atrial fibrillation, AFib, first, what your symptoms were, the way you were feeling, your steps, your course and pathway right up to treatment. And then later on, Ed, we might talk more specifically about the treatment options that you availed of. So over to you.
Thank you very much for the opportunity to join you all. The reason that I wanted to get involved in this is because I perhaps delayed going to get medical treatment, and I would like to encourage everybody who has a cardiac arrhythmia to get medical treatment as early as possible. It's actually not as scary as you might think it is. I started noticing that I wasn't able to walk the hills, move as quickly as I would have been able to. I'm 51 now. When I first started getting symptoms, I was 49. I didn't feel I was quite ready for this kind of a problem, and I certainly went actively ignoring it. And I started treating myself in that I was cutting back on the activities. It was causing me stress. I was eating more, doing less exercise. I was enjoying my wine in the evening. I was always a quality rather than quantity guy, but I still was drinking a glass of wine in the evening. And I would find that at 9 o'clock at night, when relaxing, watching some telly, my heart would take off, and I didn't really understand that. I just thought, oh my goodness, I've got a problem, I'm going to ignore it. And COVID helped me to do that, because everybody was terrified of going into hospitals, and I had these symptoms through the COVID period. But when you talk about COVID as well, and you talk about complicating factors or other risk factors that that everybody was talking about at the time, it's just making them more and more scared. So at some point, my wife managed to get me to go to the GP, and I would encourage people to go earlier.
So Ed, you found that it was impacting psychologically as well as physically on you? You found that quite challenging? Yeah,
so I'm actually was a medical rep selling to GPs in the early part of my career, and I had some cardiovascular training in the 90s to promote pharmaceutical, or as my sisters used to say, sell drugs in Manchester. So I had some level of understanding of what arrhythmia was and what the 90s treatments were, surgical treatments were, and I certainly didn't want any of those. And I didn't actually even bother to go and find out what the modern treatments were.
Okay. Were you tired? Were you exhausted? Were you?
So one of the things that really stuck with me was the family. We'd met up with a group of friends, and we were climbing a hill that I really should have been able to do. Okay. And I was really struggling. And at one point, I didn't even complete it. And I turned around and came back again. So there were 2 or 3 occasions when I went to do something and found that my body was letting me down, and okay. And that I stopped and turned around and went back again. And this only built on my anxiety, and it only built on it meant that I wasn't doing exercise, which was meaning that I was putting more weight on. And by the time I went to the GP, I was well into the middle of the obese range in the BMI. I know that's a topic for discussion about whether the relevance there, but I was heavy, really heavy. And I also had uncontrolled blood pressure. I had cholesterol issues. I was starting to really crank up all these risk factors that everybody talks about.
And you can attribute all that to your atrial fibrillation.
So I don't know whether I can attribute it all to
in yourself at that time.
I knew that the fib was important, yes. and I ignored it.
Okay, thank you, Ed. John, if I can come to you, are these some of the similar symptoms that you would find people saying to you when you're meeting them, when they're discussing treatment options for their atrial fibrillation?
Yeah, thanks very much, Trish and Ed. And I'd have to say, Ed, I admire you for coming on and sharing your story, and it certainly is very consistent with the story that a lot of people. It is obviously very variable. There are a group of people who just wake up suddenly at night, their heart is racing and pounding, and within a few minutes they're in an emergency department. But it's very frequent also that there's a more gradual and insidious onset, and essentially it's, well, I've lost a little bit of my exercise capacity over the course of the last 6 months. And it's because my heart is beating less efficiently. Well, the reason is the heart is beating less efficiently and sometimes a little quicker. And so patients come for review to try to work out what's going on. And sometimes if it's what we call paroxysmal atrial fibrillation, you're just in and out of atrial fibrillation, you may not catch it immediately with the GP or primary care doc. And often that's a source of a lot of frustration for patients. But as things move on, atrial fibrillation tends to become what we call persistent and is present more frequently. And at that stage, it's a bit easier to pick up. Ideally, we like to try and pick it up and diagnose it in the paroxysmal stage when it's easier to notice it, or easier to kind of have a long-term treatment that's potentially a cure. It's important to note also that for many people, about 40% of people who we see in clinics, atrial fibrillation is asymptomatic, particularly in older patients, particularly in males. And because of that, it has a high rate of stroke, as Dr. Hannon will go through later on. So it is important, if you do have risk factors for atrial fibrillation, diabetes, hypertension, and as you're getting older, to get a routine check, even when you're not feeling unwell, as Ed was, just to check and make sure your pulse is okay and everything is well controlled, because atrial fibrillation is an important thing to try and be aware of and to monitor and treat to reduce your risk of running into further trouble.
And can I ask you, John, if you wouldn't mind explaining to people that may have heard the term atrial fibrillation, to explain exactly what it is, what happens to the heart when somebody has atrial fibrillation?
Yeah, certainly. So usually, I mean, I suppose a bit of a nerd in terms of the what's going on within the heart. Going back to med school, I thought was a phenomenal thing. So we've got about 100,000 heartbeats per day, and they are happening all the time as we're sitting here watching TV, going a bit faster if we're going for a walk, and it's all incredibly well regulated. And so the pacemaker natural cells that we have in the upper chambers of the heart beat initially, and then there's electrical signals that go down towards the lower chamber of the heart, and the lower chambers beat and send blood through the lungs or around the body. And that cycle works incredibly well and is very efficient. In atrial fibrillation, that normal, regular, clockwork rhythm of the heart is replaced, because in the upper chambers, instead of beating in a slow, steady pace at about 70 to 80 to 90 beats per minute, there's a rapid, chaotic rhythm that's going at about 300 plus beats per minute, and it's fibrillating or flickering. So it is kind of as it says. So instead of just beating in a nice rhythmic way, it's kind of fibrillating like this. And that means that the upper chamber of the heart doesn't empty quite as regularly or as efficiently as you'd like it. And it also means that frequently the heart rate, the lower chambers of the heart, not always, but in most patients, beats a bit quicker. And that essentially is what atrial fibrillation is. And the worry is that with the faster heart rate, that can put additional strain on the heart, increasing risk of heart failure. And where there are areas of the heart where there can be stasis of blood and the blood can pool, it increased risk of clot and therefore risk of stroke, which is a key thing for patients with atrial fibrillation, that we monitor them for risk of stroke.
Yes. So it is that irregular heartbeat of the chambers of the heart where the electrical impulses aren't doing it there as efficiently as normally, and it can send the heart into a fast, irregular heartbeat and leading to issues with pumping of the blood through the heart and out to the body.
Yeah, so usually we'd expect about 10% of your cardiac pump function would be reduced. Okay. And for some people, their heart rate isn't very fast at rest, but on exertion, it will ramp up quite rapidly. So it might be 80 or 90 beats per minute at rest, and you'll feel okay. But on exertion, it goes up to 160 with this irregular rhythm, and can impact significantly on your exercise capacity.
And then some of the symptoms that some people might experience, so is dizziness, shortness of breath, any of those common symptoms, that some people may be experiencing, and it may not be atrial fibrillation, or it may be atrial fibrillation that's causing their symptoms.
So more specifically to atrial fibrillation, the number one symptom that people get is palpitations, and that can be anything from feeling like a butterfly in your upper chest to shortness of breath, which is maybe less specific for atrial fibrillation, but a common symptom that people get. Chest pain is thankfully less common, though if your heart is beating very fast and you try to exercise, that can put a bit of strain on the heart and cause chest pain. You can get some swelling in your legs, which is again predominantly heart failure, but may reflect the fact that the atrial fibrillation is putting a bit of strain on the heart and causing atrial fibrillation or heart failure. Fatigue is a common symptom. I mean, obviously there are 1,000,001 causes of fatigue, but atrial fibrillation can lead to fatigue. And then, as I said, people can be completely asymptomatic.
Okay. Niamh, if you don't mind, I might go over to you and so to discuss the link between atrial fibrillation and stroke. So how can a problem with your heart actually end up causing a stroke? If you can talk us through that, please.
Yeah. So John touched on it there, that where there is a sort of an ineffective emptying of the chambers of the heart, that the blood is allowed to pool, and no more than if you spill some blood onto a table beside you, it would form a clot. A clot can form within the chambers of the heart, and then unfortunately it just lurks there, and at any time can break off, and at some stage can make a direct route up to the main arteries supplying the brain with oxygen. And once that clot finds itself getting lodged, it causes a complete obstruction to the blood flow. So areas of brain tissue become deprived of the oxygen and nutrients that they need to function. And that's effectively what causes the clot type of stroke, which is the most common type of stroke, about 80% of strokes, with about 10 to 15% of strokes being the bleeding type. So when you have this clot type stroke, it can be a spectrum of symptoms, but unfortunately the type of stroke that we see with AF tends to be a lot more severe. And the reason is it's a different type of clot. It's actually, if you looked at it under the microscope, it looks different to some of the other type of strokes that people experience. It's quite a tightly formed clot, and it's a very tends to be quite a large clot. So as you can imagine, if it blocks in a large vessel, it's going to cause a significant obstruction. So a significant amount of brain tissue can be deprived of oxygen behind that obstruction. So we really worry about these type of strokes because they can be associated in the worst case scenarios with death, but in a lot of cases with very serious levels of disability. And in some circumstances, patients may even need nursing care for the rest of their lives because they're significantly disabled by these clots. So that's why when I come at it, and yourself as well, Trish, we come at it from a very different perspective, where unfortunately the worst has already happened, and that's what doubles our passion then for trying to protect people from ending up in that situation. I mean, we don't want to see you in our A&E.
Oh, thanks. And to concur with you, Niamh, yes, sometimes when you present with your stroke, it might be the first time that your diagnosis of atrial fibrillation has been made. And if you come with stroke to the hospital and we can't really find a cause, well, Niamh and I and our other colleagues will look quite hard for atrial fibrillation to prevent or reduce your risk of having a further stroke.
Absolutely.
Yeah.
1/3 of all strokes are actually associated with this cardiac arrhythmia. So that's quite a high proportion. And as you said, Trish, in some circumstances, the patient will overtly be in AF when we see them in the emergency department, but this is the first time they've ever known about it. Or sometimes we'll be highly suspicious that they're coming, that paroxysmal AF that comes and goes, and that we're just not capturing it on our cardiac recording machines. So as you say, we will chase and chase and chase until we're absolutely satisfied that we've looked hard enough, because we do have treatments that can reduce the risk of stroke or of a second stroke if one has already occurred.
Okay, and we'll be moving on to some treatments in a minute, and maybe this might be an opportunity just to maybe ask a couple of questions that have come in relation to diagnosing stroke atrial fibrillation, not stroke. Apologies. So somebody has asked about cardiac monitors and wearable devices, or ones that go in under the skin. Your thoughts on that, or even some of the smart devices like the watches, the phones, the apps that can pick up atrial fibrillation. Do you have any general thoughts on these devices? I know we use them from a secondary prevention point of view in stroke. John, do you have any preference, or I suppose when people are coming to you, they may already have had their diagnosis of atrial fibrillation, but just in general around how everything is now so at hand in today's society?
Yeah, I mean, we have multiple great examples of patients who were unaware that they had atrial fibrillation until they got a gift of a smartwatch and diagnosed that they had atrial fibrillation. So it is phenomenal, the technology that's out there. Smartwatches such as the Apple Watch, now Fitbit watches, and Withings watch as well, can run off ECGs very easily. And then they can be stored on your phone or on your smartphone or on your watch, and can be emailed on or can be brought into a clinic for review. They are very useful because they're quite quick to use. can be a little bit pricey, and some of the Apple technologies go into the hundreds of euro. Another device that we use quite frequently within our clinic is something called an AliveCor. That's ALIVECOR. And the AliveCor device is a little bit more affordable. It's still about 100 euros or so. But for patients who tell us that intermittently their heart races and older types of monitoring haven't been able to accurately diagnose them, or when they're wearing these devices, they haven't had any runs of atrial fibrillation. For those patients using their own device at home, and basically they have a small little band, they put their fingers either side of their band, put their phone up beside it, and it runs off an ECG on the phone. And for anyone who's interested, if you Google them, it's quite easy to find those devices. Implantable monitors, I would tend to reserve for patients who've already unfortunately had a stroke, and we feel that atrial fibrillation may be a cause of their stroke, because the general treatment for patients post-stroke would be just aspirin and other medications such as Plavix. But if they have potentially atrial fibrillation, so for example, if, as Dr. Hannon went through, they've had multiple areas of stroke seen on their monitoring, or there's a feeling that they've underlying atrial fibrillation, then we implant a small little device that sits just to the left of their breastbone that monitors for atrial fibrillation. That, I think, is not something that people usually need to have on a regular basis, because that would tend to imply that most people are asymptomatic. Mm-hmm. And what we're trying to do is deal with a symptom and diagnose the symptom, and therefore handheld devices tend to work better, I feel anyway, in my practice. I don't know, Ed, maybe have you used any of those devices? How did you find using those?
Yes, I was encouraged to purchase a cardiac monitor. So it was able to produce a 6-lead ECG on my phone. I mean, the technology was wild as concerned. When I first was going to see, I went off for a plethora of tests, but everything seemed to come back as being okay. I didn't have any blockages in my arteries. The cardiac muscle was performing properly. It was me that actually my heart feels like it's. And is there there was no proof of that, because it was just me talking about it. In the clinics, my heart was fine, and it seemed that the more activity that I was doing sometimes was keeping the arrhythmias away. That's the way it felt to me. I don't know whether that's true or not, but I knew that I was getting these arrhythmias, particularly in the evening time, that they would last. Initially, they were lasting for 5 or 10 minutes, but at this stage, I was getting to sort of 90 minutes, and going to bed and sleeping with it, and snoring incredibly loudly, and all these things that were I didn't realize they were associated at the time, but it seems that can even be can be part of it. So I got the cardiac. One of the things I wanted to say is that they are pricey, but you can claim if you've been encouraged to buy them by a clinician and have a letter, then you can put that against your tax, and you can actually get some of that tax back, which reduces the price by 1/3, which is worth mentioning. So I was able to, as a result of having these ECGs that I was running at 10 o'clock at night, the doctor was able to diagnose both atrial fib and atrial flutter, and so that the treatment I got was more thorough as a result of being able to prove that I had both fib and flutter, but that's for another day.
Thank you, Ed. I suppose just leading on to devices then, John, pacemakers, if somebody has atrial fibrillation, do they require pacemakers? Sometimes people have pacemakers in, and they may detect atrial fibrillation sometimes, and sometimes they may not. So I know pacemakers, I know because I work in healthcare, pacemakers are usually used for other conditions. So if you can just maybe discuss a little bit about pacemakers.
Yeah, the primary indication for putting in a pacemaker would be that the heart rate is going too slow. So it's what we call bradycardia. And the atrial fibrillation is usually fast, so it's usually a tachycardia going fast. Now, for some patients, when they, particularly if they've got a low resting heart rate, if we put them on medications that stops their heart rate going too fast, their heart rate may end up going too slow. So you can end up having a pacemaker to stop the heart rate going too fast and the medication to stop the heart rate going too slow. That's not common, but can be used as a technique to control the heart rate in atrial fibrillation.
Okay.
And other patients, particularly as they get a little bit older and the heart slows down, the atrial fibrillation may begin to slow a little bit, and they may end up with pauses within their heartbeat from time to time. And in that case, we implant a pacemaker. Okay. But pacemakers are not a very common treatment for atrial fibrillation.
Okay. So if we move on then to talking about treatments, we might look at, in this section, maybe looking at it from the cardiology point of view, from medications to procedures. And Niamh, we might discuss with you then around anticoagulation or the use of different medications from a stroke prevention point of view, and try and tie it in together. So if we start with medications first, John, common medications that may be used to treat atrial fibrillation. I know it's very broad, and we maybe just take a broad approach rather than going down like individualized routes. Okay. So maybe it's just a general. Okay. So you've got your ones that control your heart rate. You can have medications that can control your rhythm, and then maybe if there's a heart failure is implicated as well.
Going broadly, I think the first thing we need to do is actually, even before we get to medications, is to look at lifestyle. Okay. Why a patient may be in atrial fibrillation. So if you don't mind, Trish.
Not at all. No, that was, yeah, we can go to that one. Yeah, sure.
That's to be honest, key, because ultimately, if you say, for example, in terms of lifestyle, things I tend to look at is how much exercise is the patient having, weight, which is critically important in terms of controlling their atrial fibrillation, the presence of something like sleep apnea. So if you find that you're snoring a lot very heavily at night, as Ed alluded to earlier, if you find that your partner has noted that you're pausing with breathing when you snore, or if you're tired when you wake up and feel that you need to have a nap in midday, sleep apnea increases pressures in the heart and increases atrial fibrillation and increases stroke and heart failure. So that's the first thing, because the treatments for atrial fibrillation, if you have underlying sleep apnea, won't really work very well. Exercise is very important. If you have a sedentary lifestyle, you're likely to develop atrial fibrillation over time. And so even increasing your exercise capacity to a small degree can significantly reduce your risk of developing atrial fibrillation. Alcohol, if you have predisposition towards an alcohol binge, basically the less you drink, the less likely you are. They're the first things that we discuss. The second things we go through are stroke prevention strategies, which I'll leave to Dr. Hannon. And then in terms of your atrial fibrillation, the next steps are, well, are you symptomatic or are you not symptomatic? If you have symptoms, then we would adopt what we call a rate controlled, if we have no symptoms, we'd adopt a rate controlled strategy where we just make sure that the heart rate doesn't go too fast, and try to moderate any risk of heart failure which might occur because of the excessive heart rate. And usually we use medications like beta blockers or calcium channel blockers. And digoxin can be used as well. And then if we find that people are symptomatic of their atrial fibrillation, we go down the route of rhythm control strategies. And rhythm control strategies could be something like a cardioversion, where you get a shock to bring you back to normal rhythm. It could be medications, Cordurone, flecainide, sotalol, or it could be an ablation strategy. And previously we used to go down the route of putting people on medications first, and then if the medications weren't working, go down the route of ablation. But increasingly it's more common that we go to ablation first, because our general sense is that ablation, if you do it earlier, tends to have a better long-term efficacy in terms of keeping the heart in a normal rhythm. And that's usually the treatment strategies that we go through for atrial fibrillation.
And do you mind, just for people that may not know what cardioversion is or ablation, would you mind just explaining that in a little bit more detail, John, if that's okay?
No problem at all. So the way I think about atrial fibrillation, cardioversion and ablation in a simplistic way is that if you have a problem with your computer, the first thing that you do is you turn it off and you turn it on again. And you know, sometimes that works. And even when you call IT, that's what they tell you to do.
Guilty.
So a cardioversion is essentially giving your heart a shock, and the shock pauses your heart briefly, but that pause is enough for the heart's normal beat to recover and come in. Now, if you're getting atrial fibrillation from time to time, very much paroxysmal, that's not going to work because you're going in and out of atrial fibrillation. But if you're on an ongoing basis, again, persistent atrial fibrillation, then a cardioversion would work. And sometimes we do a cardioversion just to try and see, is a patient symptomatic or not? Because again, if someone is cardioverted, they revert back to normal rhythm, they may often come to clinic and say, actually, I feel much better. And that prompts us to go down the route of a rhythm controlled strategy. Ablation is when you bring your old dodgy laptop to the computer store and say, this needs rewiring, this needs to be fixed. And essentially it would involve us going into the heart, trying to look at the source of where the atrial fibrillation is coming from. And most commonly that's a source around the pulmonary veins on the left side of the heart, the left upper side of the heart, and the left atrium. The pulmonary veins drain blood from the lungs into the heart, and there are sleeves of tissue around that area that fire quite rapidly, causing atrial fibrillation.
Okay. So
we, by going around that spot and either cauterizing it or sometimes freezing it, or there are new technologies that are available now as well, we basically electrically isolate those pulmonary veins in a procedure called pulmonary vein isolation. And if you have flutter, as Ed had as well, there's other little focal sources that we tend to look at. So that's what ablation is and cardioversion. So usually with a cardioversion, patients will essentially, it will always recur at some stage. It depends on the timeline. It may not run into trouble, for a few years, but you may be leaving the hospital, and by the time you've driven home, you're back in atrial fibrillation. Okay. And we would hope with ablation, the 1 year freedom from atrial fibrillation that we'd usually quote is about 75 to 80%, depending on some other underlying factors.
Okay. Thank you, John. That's very, very well explained. Thank you. So Niamh, if we may go to you then and look at stroke reduction, the risk of having a stroke as a result of having a diagnosis of atrial fibrillation.
Yeah, I wish I had a nice laptop analogy like that, but it's a little bit more simple from our end, and hopefully in our scenario as a stroke team, we'd be discussing it with patients who've had a minor stroke or hopefully a mild stroke or TIA that they've fully recovered from, and our principle is to protect them from a second stroke. But of course, it also works for primary prevention in a patient perhaps who attends their GP. Even something as simple as a pulse check might identify atrial fibrillation, and we would hope that opportunities can be taken in those settings to try and protect that person. The first thing to do is to assess their risk of having a stroke, because actually young people get AF and they wouldn't necessarily have the same risk factor profile as some of our older patients. It's less common to have AF as a young person, and it's also less common to have that full house of risk factors that older people might have. So generally speaking, if a patient is risk factor free but has AF in a younger age group, they may not end up needing anticoagulation because their stroke risk would be perceived as low. And the reason we don't just blanket anticoagulate everyone with AF is because unfortunately it is quite a strong medication approach. It's effectively what people describe as a blood thinner, although it's not thinning the blood, it's reducing the ability of the blood to clot. So needless to say, if you're taking that medication and you have some sort of trauma that causes you to bleed, you can bleed for longer. So we need to be very careful when we're making our decision that the person we're giving this medication to has benefit from that medication and that the risk is not excessive. So not everyone will be anticoagulated. However, The majority of older people, so certainly talking above 80s and possibly even above 65, will have at least one other risk factor for stroke. And having something like diabetes, hypertension, cardiac failure, a smoking history will automatically push you into a higher risk category, where we could say that your risk of having a clot type stroke is going to be higher than the risk of taking a blood thinning medication. Now, in the olden days, we used to effectively use rat poison, which was basically a medication called warfarin or coumarin, which was also used by farmers in their sheds to take care of any pest problems. Thankfully, the situation has moved on, and we now have a range of newer agents called the direct oral anticoagulants, some of which you take twice a day, some of which you take once a day, but we know that these are not inferior and are equally effective as the old-fashioned warfarin. And we are all now getting very comfortable in the last 5 years with using those medications and actually having quite a lot of success with stroke prevention. I do need to mention they're not 100% efficacy, but you can see up to 80% efficacy. And my own research has shown that if you are taking one of these medications and are unfortunate enough to have an AF-associated stroke, it does actually reduce your risk of suffering a severe disability from that stroke. So there's definitely a major change in terms of stroke management and a very important part of our stroke prevention where we deem a person to be at high risk of having a clot type stroke.
Niamh, can I ask you, is there a difference between these blood thinners, these oral anticoagulants, say from aspirin or Plavix? Is there a difference between these drugs?
Yeah, that's a very commonly asked question, and particularly when I've just mentioned that these are risky drugs to use, that they increase your risk of bleeding. But I did touch earlier on the fact that these clots are different, and unfortunately, the aspirin just doesn't cut it when it comes to secondary prevention or primary prevention from an AF-associated stroke. The aspirin works in a different part of the clotting within the blood, and the newer anticoagulant agents actually focus on the materials that cause these dense, big clots that cause the nasty strokes. So where an aspirin dose will offer you up to 20% risk reduction, the DOACs will offer up to 80%. So obviously there's a huge difference in terms of the ability to reduce your risk.
Okay, and I suppose for anybody out there that is concerned, go and talk to your general practitioner. As John said, look at your lifestyle, look at what you're doing to yourself as well. So leading a healthy cardiovascular lifestyle, so knowing your blood pressure, watching diabetes, watching your cholesterol. John or Ed, you alluded to it earlier on that as you were going through, not feeling well, you were becoming more sedentary. You were falling into that vicious circle of I'm not able to exercise and I'll have another glass of wine. That you can suddenly find yourself even in deeper waters from a cardiovascular risk point of view as well. So
I'd agree. I think one of the important things is sometimes you need to get your head around it that there's something wrong.
Yes.
And certainly it took me 6-12 months to actually decide, well, there is something wrong and I'm now going to do something about it, as opposed to there's something wrong, I can just get away with it and let it move on. And so I had a lot of risk factors when I was initially assessed medically. So I had cholesterol and I had blood pressure issues. I was my BMI was I was in the middle of the obese section. I had radically reduced the amount of exercise that I was doing, and I was getting arrhythmias. And so it was all of these things adding on and adding on and adding on, and it was I'm 50 years old. I've got a young family. I've got three teenage boys. A small business that people depend on salaries, and stress is there, and it's just exacerbating everything all the time. So what I'm trying to get to is encourage people to go and get that medical treatment, that assessment as early as possible. It took me a year. If I'd gone 3 months after 3 months, I might have helped myself in reducing the risk factors. Blood pressure is now controlled, so that's no longer a risk factor. I'm taking drugs for it, but it's controlled, so it's no longer a risk factor, as I understand it. Cholesterol is controlled. Again, I'm taking something for it, but it's now controlled. Weight has come down. It could go down more, but you know, I've lost 15 kilos, so I've moved from obesity to overweight, and if I can get down to normal weight, then so much the better. Over the course of a year, and activity's gone up. So I had the ablative treatment, and the doctor actively encouraged me to get out and start moving, and so I actually chose to have my procedure done on a Friday of a bank holiday weekend so that I could be back at work on Tuesday, and that was effectively what happened. I thought I'd get more time off, but I was well, so I went back to work. But what I did do is on the Saturday I went for a walk, which I hadn't done for a long time. On the Sunday, I did the same walk again a little bit faster. On the Monday, I did the same walk again a little bit faster. And then started to, I walked every day for 6 months, and I started to bring in hills and try to make it so that I was pushing a sweat at some point, but always doing it, trying to get the weight loss down, trying to see whether I was still going to have a cardiac arrhythmia, none of which actually happened. So I kept going. And last weekend I walked Lugnaquilla with the family, which was an achievement.
Congratulations. And so you have had ablation, Ed. Would you be able to talk us through your experience of the procedure, if that's okay, if you don't mind?
Sure,
if you'd be happy
absolutely.
to share it.
So I was referred on from my GP initially to a specialist who was focused on sudden cardiac death, and that focuses the mind when you get referred to a specialist like that. And I got an echo to see whether or not that there was a problem there. I got the veins were checked, and largely I was okay. So it came back to this arrhythmia that I was having. So I went to a different specialist, and from that specialist, he encouraged me to get a cardiac, so that I was able to then prove the atrial fib, and in this case the atrial flutter as well. John will go into more detail on that, but I had both procedures done at the one time. So they go into one side of the heart for fib, and they go into the other side of the heart for flutter. I'll let them get into the detail on that. But I have to say, when you actually start thinking about what they're doing, it'll blow your mind out of the water. I mean, you just think they're going to do what, and how are they going to do it? And okay. And, you know, I wrote the letter when I don't wake up. What's going to happen, because you're scared out of your mind as a patient going into that situation. So it was 7 o'clock in the morning. I asked to be on the list early. I wanted to get done. There were a lot of patients. There were 7 patients being treated that day. It was I thought I was young, but actually there were younger people getting treated that day. One of the guys, looked like he was in his 20s. I mean, I thought he was very young. And that actually encouraged me again. So I went in, I was anesthetized, I was treated, and I woke up in the ICU, which is where you're supposed to wake up. You know, my heart, I felt great. I didn't feel great, actually. I felt terrible after the anesthetic. Made me as sick as a dog, and I was really struggling with the anesthetic, but my heart wasn't racing, and I felt that it was good. Actually, do you know what? The heart rate was higher than my normal resting rate was by about 10 or 15 beats per minute, but I was then told that was normal, so I was delighted with that.
Good.
And you wake up in the ICU, and you're encouraged to eat and get active, and you're home the next day. And as I say, you're sore, and you're getting over the anesthetic, but generally speaking, it's the relief of having it done was immense for me.
Great. And you've been well since, Ed? You're feeling well?
So it's interesting, because there were people in getting their procedures for the second time that might have had it 5 or 6 years beforehand, and I hadn't realized that this might be a repeat thing for me. As I mentioned, I'm on products for my blood pressure and for cholesterol, but I'm not on an antiarrhythmic agent because I haven't had any more arrhythmias following the procedure. It's possible that they will come and I will go on an antiarrhythmic, but that's not the case at the moment. And the other thing is, we have a small farm of activities that I enjoy doing. I didn't want to be on blood thinners, or I was concerned that if I bruised or I cut myself, that I'd be in more trouble that way, and I wanted to get back to different activities. And so I think weighing up the risk factors for me, it was, if I can be more active, I'll probably lose more weight. I'll probably get my cholesterol down. I'll probably keep my blood pressure down. It's probably better for me to go that way rather than keep taking more and more tablets trying to treat these things. I felt that I wanted to get the lifestyle changes right first. I didn't give up alcohol, but I was encouraged. I was never a heavy drinker. I was quality kind of rather than quantity. But I don't drink during the week now, and I've really, really radically reduced any alcohol intake. I did find that before I knew alcohol was had an effect in the heart, I thought coffee would be a bigger deal, and I actually had come off coffee myself. And then when talking to the specialist, he said, "Look, coffee, I'm not too stressed about it. Go back on your coffee. Just stop having the wine at 7, 8 o'clock with your dinner, and that might have a bigger effect for you." So it was no big deal. I just stopped having that wine at dinner, and it's an easy fix, and you want as many easy fixes as you can possibly get, I think, because you've got this condition for the rest of your life, so you just want to. I'd rather not have to go and have another ablation if I can avoid it. So if I can reduce my weight, and if I can reduce the alcohol intake and keep my blood pressure under control and keep my cholesterol under control, then maybe that will reduce my risk of having to go for another ablation.
So you're living well, to take the title from this series tonight. You're living well with your atrial fibrillation. You've taken control. You come across to me, Ed, if you don't mind saying, that somebody who has educated themselves about their condition. You've understood what it is. You've understood to, as well as from what the doctors could tell you, the cause, what was causing your atrial fibrillation, and then the lifestyle modifications that you needed, not alone to reduce your risk of having a recurrence of your atrial fibrillation, but reducing your risk of heart disease and stroke disease and cardiovascular disease as you age, going into the future. So well done you.
So some of the things that were quoted to me,
it scares you a bit.
But about lifestyle changes. If you stop drinking alcohol, alcohol has a major effect on the electrics in the heart. I mean, the wine industry loves talking about a glass of red wine being good for the heart, but for electrics, that's not the case, apparently. So stop. And that was easy for me. It wasn't a big deal. And I'm not saying I'm teetotal. I do have the occasional glass of wine, but it's occasional now as opposed to on a reasonably regular basis. And I think if it's like all things in moderation, and if you can get back to your activity, then that's going to help.
Thank you, Ed. John, if I can come back to you, I just see somebody, Peter has sent in a question there, and Ed has mentioned it already, the difference between AFib and A-flutter. I know they're maybe opposite side of a coin, maybe, but I'll let you explain it maybe a bit better.
So fibrillation and flutter often coexist within patients, and people who have fibrillation or flutter, we'd often say that there's about a 50% chance over 10 years that they'd have fib as well. Flutter would tend to be divided into typical flutter and atypical, but generally what typical flutter is, which is what Ed describes, is a rhythm that's initiated in the right side of the heart, in the right atrium. And instead of the kind of fibrillation like this, it's just a circular rhythm and rate that's going at about 300 or so beats per minute. And when we see flutter, often it's harder to control the heart rate with flutter. It still has a stroke risk associated with it, though probably not as high as fib. Still, we treat it along the same lines. We do tend to get, I certainly have a lower threshold even for flutter, for going for a flutter ablation, because the success rate is very high with it. We're talking about 90 to 95% success. And so what essentially, because you've got this little circuit that you go through, and it's very much anatomy dependent, once you cauterize along that circuit and basically make the tissue that the circuit's going through inert and can't conduct any electrical signals through it anymore, the flutter thankfully goes away. We also use flutter as a broader term for arrhythmias that can occur on the left side as well. So there can be a little bit nuanced depending on the flutter, but for most people, flutter is quite very straightforward to deal with in terms of an ablation, and is similar risk factors for as atrial fibrillation. Now, I would certainly have to commend Ed on the way he's followed up, bar the fact he went back to work far too early. Has been a model patient, I'd say. So hats off to him. You know, weight loss is really, really critical. And we know actually with weight loss, atrial fibrillation can go away. It's not just prevented from coming back. AFib, if it's paroxysmal and you lose 10% of your weight, your AFib can go away. Now that's not for everybody, but it certainly helps. And so not infrequently we'll tell people, actually the first thing you need to do is lose weight, and then we'll kind of reassess once your weight is down a bit.
Okay, thank you.
If I may,
yes, Ed, of course.
I felt that once I'd had the treatment, it triggered in my mind that I'm better, or I'm going to be better, but I need to work at it at that point. It actually helped trigger the lifestyle changes as well. It was drawing a line in the sand where I had been sick up to this point and I'm not going to be sick in the future, and I wanted to make those changes. So I think at some point you need to make that decision, and everybody will have their own independent way of doing that. But I think if you can make that decision earlier, the better. And I certainly could have had that decision earlier if I had sought medical treatment earlier.
Okay. Thanks, Ed. Some of the questions that came in as well earlier on, I suppose people were talking about just, you know, feeling an odd palpitation, you know, an irregular beat. Not all irregular beats are atrial fibrillation. So I suppose I just want people to, or flutter for that. That you know, the people can have extra beats. They can have what we call atopics, or, you know, little funny beats dropping in or dropping out. So for people, I suppose, what as a nurse, and I know we've spoken about devices earlier on, and smartphones and watches and AliveCore and Cardicore and all of these. But for people to understand and maybe to get a feeling of what their heartbeat actually feels like. So to know for them what their heartbeat is like. And I know in a previous talk that we did with Croí around stroke prevention, is these two guys here attached to you, they don't come with wires, they don't come with apps, they're your two fingers. And if you can learn how to place your two fingers below your thumb and learn to feel your pulse and know what your pulse feels like, what is normal. And when you are sitting down in the evening and, you know, sit there for 30 seconds or a minute and get to know what your heartbeat is actually like for you. Now, if you've had a glass of wine, you may have a different heartbeat. If you've been watching something on the TV that's a suspense drama, or, you know, certain things will increase your heartbeat, but to know what your resting heartbeat is like, I think it's important. And, you know, not everybody, as we've said during the night, will have symptoms of atrial fibrillation. So if you're feeling that your heart rate is not doing that normal bump, 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 that you might be going fast, it might be going slow, it might be running off, you know, then maybe go and speak to somebody and take that first step. You know, we don't certainly want to be meeting you in our stroke unit having a stroke as a result of the first time of you having atrial fibrillation. Not everybody has symptoms, and I suppose if you do have symptoms, go speak with your GP and get those referral onwards. So look at your heart, look at your lifestyle factors, look at what healthy living, looking at leading a healthy cardiovascular, so looking after your health, your heart, your stroke risk, your circulatory system, your diabetes, your cholesterol, your blood pressure, and being aware of your body to help reduce your risk. So when you're looking at atrial fibrillation, it's having a healthy heart, and it's also sort of reducing that risk of stroke. So Niamh, if you or John have anything further to say, we're coming close to the end of the hour. It does fly by. I hope we've covered the topics well. So for people, I suppose, just to empower themselves to take control of their lives, to ask the questions and to seek the help that's appropriate for you. So John and Niamh, if you want to finish.
Yeah, I just wanted to address, there was a couple of questions that came in that I just wanted to go through. Okay. One was with respect to family history, if that's all right.
Yes,
Trish.
Sure, of course. Yeah.
Family, the bottom line, I think, is that this is the most common arrhythmia that we see. So if your father or mother in their 70s or 80s developed atrial fibrillation, that's not necessarily a kind of a strong link. There would appear to be genetic clustering in families for atrial fibrillation. So people who tend to get AFib at a young age, their family would be more likely to develop atrial fibrillation as well. But it's not, the genetics of it are quite mixed and quite unpredictable. So it's not a kind of a very strong, it's not, you've got X gene, therefore all your family will have it, but it does appear to cluster in families. And if it does cluster in families, it doesn't necessarily mean that the treatments are harder. It just means that you're more likely to develop it. So it would be important if you had a family history of stroke at a young age, or family history of atrial fibrillation at a young age, that particularly getting checked out, I think, would be relevant. Another question that somebody asked was with respect to, well, they felt that maybe that they were a candidate for ablation. I think that it is important to note that if someone's had AFib for a while, it's not always that everyone who has atrial fibrillation is a candidate for ablation, but it's certainly worth following on from any information that you have here, having a further discussion with your either primary care doc or your cardiologist to go through the pros and cons of it. So I think it's important to know that although ablation works thankfully very well, it's not a cure for everybody, and it's ultimately also a procedure where we go into your heart to try to rectify things, so it's not without risk, and all those things need to be borne in mind when someone's been referred for an ablation. But otherwise, Trish, I'd like to say thanks very much for asking me and for moderating the session. It's been a pleasure.
Thank you, John. Thank you for your valuable input. And I know there's lots of comments coming in that people are just found the evening very informative, and, you know, hopefully it's given people some answers to their questions. Niamh, have you anything to add?
I might leave the last word to Ed, actually, because I think his lived experience is really important. And I would just say, I think the take-home message for me is it's not that one size fits all. I think the key is knowing that you have the condition and then addressing with your healthcare professionals as to what you do next.
Thank you, Niamh. And Ed?
So I feel blessed that I got on a treatment path, that I had a GP who referred me into the specialist, and that specialist actually referred me on to a specialist in the electrics of the heart. That coverage is not necessarily nationwide, but it's effectively an elective procedure, and you can drive to where the procedures are available within the country. And whilst I'm not wishing John's waiting list to get to 5 and 10 years in length, the procedures are available in the country, and you can, I think if you know about them, you can make them informed decisions. You will become the expert of your heart. I know that doctors are incredibly well qualified, and they're passionate about what they have learned and what they do. But it's your heart. You have to take responsibility for it, and you have to get on with it. Thank you.
Well said, Ed. And I can envisage and back up what Ed has said. John, you're going to be getting a lot of post and mail with Galway and West of Ireland stamps on it, just heading your way. So be warned.
It's
but
always
thank
welcome.
you for providing. Yes, it's great if you can help people. It is wonderful.
Thank you all very much.
Thank you, and we'll say good night. I'll hand you back to Lisa. Thank you, Lisa, and good night, everybody.
Thank you, Trish, and thanks to all of the panel members, Ed, Niamh, John, and of course, Trish, a wonderful host. I think that was an absolutely fantastic session, so informative, so interesting, covered so many topics, and as you said, I very much hope that it covered the topics of importance to the audience. Really lively discussion there in the Q&A and in the chat. And a really wonderful number of people logged on this evening, despite the beautiful weather out there. So thank you so much for joining us. I'd like to thank our supporters for this evening again, Johnson & Johnson. And just to point out, if you'd like more information on atrial fibrillation, you can visit getsmartaboutafib.ie. I would also like to say thanks to a couple of the Croí team in the background, Bridget and Maeve, who have been keeping an eye on the tech side of things and responding to some of your questions. A survey will be going out to you tomorrow to get some feedback on this session. Your feedback is very useful to us. And you'll also receive a recording of this session that will bring you to the website, the Croí website, where the recordings of all of our webinars are kept. The recording will also go to